morning and welcome to this session on use of capnography in the post-operative and general care setting. My name is John Gallagher and I'm the Trauma Program Manager at the Penn Presbyterian Medical Center in Philadelphia, Pennsylvania. I've been a nurse for over 30 years as well as a respiratory therapist, and I will today present to you information on the use of capnography in this setting. I hope that you'll see the benefit as I have over the last 30 years of this monitoring technology. This is my faculty disclosure, and these are the disclosures of the medical education program for Medtronic. Today in our session, we will do three things: describe the risk factors associated with the development of respiratory compromise in the postoperative and general care setting, identify risks associated with intermittent respiratory monitoring, and identify current respiratory monitoring technologies that might be utilized to detect respiratory compromise and how it may be applied in your clinical practice. What is it that we do? As clinicians, we have an awesome responsibility to create the safe passage for our patients through the healthcare experience. They come to us for treatment, and it is our job to treat patients for their immediate problem, but also protect them from complications of injury and illness and the associated treatments that we give them. These are the faces of respiratory compromise. These are individuals who came into the hospital for relatively routine procedures and never left. They suffered respiratory compromise, and because of the combination of opioid or sedation agents along with the inability to continuously monitor them, these patients developed respiratory compromise and it was undetected. Subsequently, there was a failure to rescue and these patients lost their lives. The goal for this program is to help everyone to understand the benefit of continuous monitoring and to prevent respiratory compromise from progressing in these situations. What is respiratory compromise? Respiratory compromise describes a deterioration in respiratory function in which there is the possibility to progress onto respiratory insufficiency, failure, and arrest. And often, these circumstances can be mitigated through not only identifying patients who are at risk, but also applying monitoring technologies in a continuous fashion that allow us to detect it and prevent it from progressing to a catastrophic event. Respiratory compromise has three main components. One, respiratory decompensation, where a patient can progress from insufficiency to failure to arrest. It's multifactorial and comprised of patient host factors, clinical conditions for which the patient is presented to the hospital, as well as treatment interventions that we may perform that may put the patient at increased risk. And respiratory compromise is progressive, meaning that it can progress further and be detected earlier through adequate monitoring. Respiratory compromise occurs in about 1 in 8 surgical patients. It's twice as common as post-op cardiac arrest, and its incidence ranges from about 1.5% to 7%. Respiratory compromise in the postoperative patient is greatest within the first 24 hours after surgery. 81% of critical respiratory events occur during this time, with 75% of deaths related to critical respiratory events also occurring, and 77% of naloxone reversal of postoperative narcotics for pain occur within the first 24 hours. When we look at the postoperative opioid-induced respiratory depression, it is a significant cause of death and brain damage in these patients. In reviewing 357 cases from an anesthesia closed claim database, 77% resulted in severe brain damage or death. 88% of these occurred within the first 24 hours of surgery, and 97% were considered preventable with better monitoring response. The factors that contributed to these cases including multiple prescribers, concurrent non-opioid medications which may have increased respiratory compromise through oversedation, and inadequate nursing assessment and response. When we compare the mortality of patients with post-op respiratory compromise, those who develop respiratory compromise have a significant increase in mortality over those that do not at 30 days, 1 year, and 5 years. 2 studies looking at specific populations of patients postoperatively showed that in patients with thyroid and parathyroid surgery, there was a 300-fold increase in patients' mortality who had respiratory compromises versus those that didn't. And in a similar study, a 147-fold increase in mortality for patients that developed respiratory compromise versus those that did not. Delay in identification of respiratory compromise also results in delay in interventions for those patients. Delay in interventions occurs in 50% of patients with respiratory distress, and that delay in making an intervention is associated with an increase in mortality. Units where intermittent physiologic monitoring is employed and standard of care, and ratios of nursing between day and night result in diurnal variations in interventions at a much greater rate, meaning that with those units, there is a difference in the response to these events between day and night. Our goals in preventing and treating respiratory compromise involve anticipating it, detecting it early, and early interventions. Anticipating it means that we need to identify those patients at risk. Once that's done, we need to detect early respiratory compromise by placing those patients on continuous monitoring. That monitoring can be oxygenation monitoring as well as ventilation monitoring, and through the use of that, detecting early the progression of respiratory compromise so that we can apply rescue maneuvers such as airway repositioning, assisted ventilation, and even naloxone rescue if necessary. Populations at risk for respiratory failure include those with obstructive sleep apnea, 90% of which may be undiagnosed, patients with morbid obesity, those with extremes of age, especially the elderly who have an increase in the chance of developing respiratory compromise with each decade of life after age 60. Patients who've had no previous opioid use may be sensitive to even smaller doses and develop respiratory depression, as well as those patients where escalating doses are required in order to treat their pain. Patients with concomitant sedative agents in addition to the opioids may have a synergistic effect, increasing their risk for respiratory depression, as well as those patients who have thoracoabdominal surgery, pre-existing cardiac disease, long duration of general anesthesia, as well as a history of smoking. In order to illustrate the trajectory of a patient with respiratory compromise, let's look at the case of Mr. Jerry Clark. Mr. Clark's a 52-year-old male working on a ladder at home when he falls from the ladder onto his left side. He immediately complains of left-sided chest pain and notes that it's very hard to breathe. When EMS arrives at the scene, they note that he has left rib pain on palpation. He's transported to the trauma center, and on arrival, he's noted to have a pulse oximetry of 96% on 4 liters nasal cannula. His incentive spirometry reveals an inspiratory capacity of 600 milliliters, and his CAT scans reveal rib fractures on the left side, 4 to 6, as well as a grade 3 splenic injury without blush. His vital signs include a heart rate of 110, his blood pressure is 150 over 92, and his respiratory rate is 20 and shallow. His pulse ox remains 96% during the resuscitative phase of care. On admission to the trauma step-down unit, Mr. Clark undergoes non-operative management of his splenic injury, pain management for his rib fractures, and also pulmonary therapy to prevent pulmonary complications associated with his injuries. He's placed on continuous EKG monitoring, as well as respiratory rate monitoring and continuous pulse oximetry. His treatment includes 4 liters of nasal oxygen, dilaudid PCA, and continued incentive spirometry every 4 hours. His heart rate remains at 110, his blood pressure 150 over 92, and his respiratory rate fluctuates between 10 and 30 breaths per minute. At this point, though, his pulse oximetry reveals a saturation of 90%, decreased from 96% on admission. 3 hours later, Mr. Clark is noted to have increasing left upper quadrant pain. His hemoglobin drops 2 grams, and he's taken to the OR for an exploratory laparotomy, where they note active bleeding from his spleen, and he undergoes splenectomy. Post-operatively, he's extubated, he's taken back to the trauma step-down unit, and he continues on dilaudid PCA. Post-operatively, Mr. Clark complains of pain of 3 to 4 out of 10 on the numeric rating scale, and he's actively using his PCA, requiring intermittent bolus dosing of analgesic for breakthrough pain. He's noted that he's sleeping most of the time and occasionally snoring. His heart rate is 110 to 112, his blood pressure 138/92, and his respiratory rate fluctuates between 6 to 10 breaths per minute with a saturation between 94 to 96%. Intermittently, the low respiratory rate alarm continues to go off, and the low amplitude waveform is noted on a respiratory rate monitor. The nurse comes into the room, increasing the waveform size, and changes the leads trying to get a better tracing, and tells him to take a deep breath, which results in an increase in his respiratory rate and saturation temporarily. 1 hour later, the bradycardia alarm is going off on the bedside monitor. The nurse comes into the room, finds Mr. Clark pale and apneic. Code is called. She begins to open his airway, notes secretions and vomitus in the airway, and suctions him and begins bag valve mask ventilation on 100% FiO2. Upon arrival of the code team, the patient is intubated, a central line is placed, and a chest x-ray is performed post central line placement and intubation. His heart rate goes up with ventilation to 110, and his saturation increases as well, and he's transferred to the surgical ICU. 2 days into Mr. Clark's course, he's noted to have refractory hypoxemia and is diagnosed with ARDS secondary to aspiration from his initial event. He's transitioned to lung protective ventilation, APRV, and he continues to exhibit septic shock physiology and is pressor dependent. By ICU day 6, his oxygenation improves, his pressors are weaned, and over the next several days, he continues to be extubated successfully, transferred out to the trauma step-down unit to rehab on day 22 and discharged home on day 29. So if we look at Mr. Clark's case, was his episode of respiratory compromise and progression to respiratory arrest preventable? What clinical information did we have about him when he came in and as he was moving through his hospital course that identified him as a potential person to develop respiratory compromise, and what type of monitoring may have been helpful in detecting respiratory compromise in this patient? In order to do that, let's look at the triad of circumstances around Mr. Clark: patient pre-existing condition, clinical conditions, as well as treatments that he may have received during his time. When we look at Mr. Clark's pre-existing risk factors, we can look at age, and we can also look at the potential that he had undiagnosed obstructive sleep apnea. This was noted during his assessment that he was snoring while he was sleeping, and remembering that 90% of these cases may be undiagnosed, he may have been at risk. Injury-related factors include his rib fractures and abdominal pain associated with the splenic injury, making it difficult for Mr. Clark to breathe. Treatment-related factors include opioid PCA, the fact that he was intubated and underwent general anesthesia, as well as his abdominal surgery, which can further make his ability to breathe compromised. Mr. Clark was receiving opioid analgesics, and there's always the risk in receiving these agents that he may experience opioid-induced unintended advancing sedation, resulting in respiratory depression and airway obstruction. The incidence of PCA-associated respiratory depression is between 1.2 and 11.5%. 29% of cases that are submitted to the Joint Commission Sentinel Event Database are related to inadequate monitoring. So continuous monitoring may have helped in this situation. This table is from the American Society of Anesthesiologists and shows the different levels of sedation from minimal to general anesthesia. When administering sedation of any type or analgesic agent, there is always the possibility that the level of sedation will progress more deeply, even when not intended to do so, based on patient conditions and other factors. Our goals for our patients are to optimize analgesia, considering patient-specific factors, to make sure that we monitor their pain, that their pain is adequately treated, but at the same time that they be continuously monitored with oxygenation and ventilation monitoring, and to be prepared for emergencies and be able to intervene for both airway and ventilation, as well as, when necessary, pharmacologic intervention to reverse the effects of analgesia sedation. Let's take a look at some of the monitoring technologies available to us in monitoring Mr. Clark. Ideal monitoring technology is one that is continuous, non-invasive, highly sensitive, highly specific, highly reliable, and also has a fast response time. We'll look at each of these technologies in turn. One of the first ways of monitoring a patient is using physical assessment. Physical assessment varies in its ability to detect respiratory compromise depending on the experience of the clinician. At best, it has a moderate to moderately high sensitivity, specificity, and reliability, but its response time is slow. It's intermittent, and your moment with the patient is the only time that you're actually able to assess them until the next time that you return. During that time between assessment, the patient is unmonitored, and this is not ideal. Respiratory rate monitoring varies in its specificity, sensitivity, and reliability depending on the technology. The most common way of monitoring respiratory rate is chest wall impedance, which works in tandem with EKG monitoring and looks at chest wall movement. This is monitoring chest wall movement, but not actually airflow through the patient's airway, and it is a poor monitor of ventilation as well as airway integrity. When we look at pulse oximetry, though quite common, its reliability in detecting airway compromise and respiratory depression in these patients varies depending on whether the patient is on supplemental oxygen or not. When a patient is on supplemental oxygen, the response time is slowed because of the amount of oxygen in reserve in the alveoli. Patient has some time where they can obstruct or have respiratory depression before there will be a change in their pulse oximetry. So in the patient without supplemental oxygen, response time may be fast, but this may be slowed in the patient with supplemental oxygen. Now let's look at the different types of CO2 monitoring. Transcutaneous CO2 monitoring measures CO2 level at the capillary beds. It has moderate to high or to low to moderate sensitivity, specificity, and reliability. However, the response time is slow when compared to end-tidal CO2 monitoring. When we look at intermittent monitoring of blood levels, venous and arterial, of CO2, this is slow response time because it's an intermittent technique. So we are only able to see a snapshot of what the patient's CO2 level is, arterially or venous, at the given time that this is measured, and then the next time that it is measured again. So while it is highly sensitive, highly specific, and also reliable, it is slow in its response time because it's an intermittent technique. Measuring of end-tidal CO2 in both the intubated and unintubated patient has high sensitivity, high specificity, and is highly reliable, and also has a fast response time because we're measuring CO2 exhaled at the airway. This provides us with three pieces of information. One, the end-tidal CO2 or partial pressure of end-tidal CO2. Two, the respiratory rate directly at the airway itself, or airway respiratory rate. And three, the CO2 waveform for each breath. Each one of these things can provide us information about the airway integrity as well as the patient's respiratory effort. Both capnography and pulse oximetry can work in a complementary fashion, though they are different. Capnography measures the partial pressure of end-tidal CO2. It measures ventilation rather than oxygenation. However, it detects changes in airway compromise as well as ventilation compromise quite rapidly. Pulse oximetry measures oxygen saturation. Values often lag behind those of capnography, especially in the patient who may be on continuous oxygen. However, the two technologies can work together in most circumstances to give you a good picture of your patient. Now let's look at the capnography waveform. Capnography waveform has two distinct segments. The first segment on the left of the diagram shows the exhalation phase. This is the part where CO2 moves from the alveoli to the large airways and is exhaled, detected by the device, whether it be an invasive or non-invasive sampling device. The end-tidal CO2 is represented by point D on the diagram and is the highest CO2 exhaled and what is displayed on the monitor as the end-tidal CO2 value. As the patient takes a breath in or the ventilator delivers fresh gas to the patient, the inhalation phase occurs and the value for CO2 drops down to 0 or baseline. Why would we use capnography? Well, capnography does two things. It identifies the compromise of airway patency. It allows us to know if gas is passing through the natural airway and is a better measure than chest wall movement. It also identifies respiratory depression sooner than pulse oximetry, especially in those patients who are on supplemental oxygen. It can detect hypercarbia and also changes in the end-tidal CO2 from baseline, either going up or down, detecting whether the patient's respiratory effort may be compromised. When we look at the growing use of capnography, we can see that between 1999 and 2016, there's been an explosion in the number of statements that have come out from professional organizations. Between 1999 and 2010, there were about 16 statements in a 12-year period. However, between 2011 and 2016, there were about 11 per year. There's a growing wave of capnography throughout the United States and Europe, and you can see all of the organizations that have put forth statements of recommendation for the use of capnography, not only for intermittent sedation, but also for the use in continuously monitoring patients on opioid analgesics. Let's look at the two ways in which capnography might help us to detect respiratory compromise. The first is in detecting compromise of the airway. If you look at the scrolling diagram of the capnography waveform, you can see how it deteriorates from a crisp waveform to one that shows compromise of the airway as the end-tidal CO2 waveform is lost. Compare that to the screen below, where we see the thoracic impedance waveform of chest wall movement, showing that the patient is breathing 16 breaths per minute and saturating at 100%. What we know is that the impedance waveform is showing us chest wall movement, while the capnography waveform is actually showing us true airway movement through the upper airway. As this patient obstructs, we see deterioration and loss of the capnography waveform. However, what we see on the impedance waveform is there continues to be movement, leading us to believe that the patient is moving air when indeed they may not be. When we look at drug-induced hyperventilation, we can see two different types of patterns that can occur. One is called gravitic hyperventilation, or type 1, where our respiratory rate can decrease. However, the end-tidal CO2 may increase over time. And we can often see this pattern in patients who are on opioids. We can also see a second type of hyperventilation called hypopneic hyperventilation, where the end-tidal CO2 decreases, however, the PA CO2 increases and there's an increase in the gradient. You see in this particular case, there's a decrease in amplitude. So while we may expect that in the patient with respiratory depression, end-tidal CO2 may rise, it may not only rise, but it may also decrease depending on the type of respiratory compromise that the patient is experiencing. The capnography waveform that you're seeing now is actually one from a patient where we see hypopneic hyperventilation. We see a decrease in amplitude of the patient's end-tidal CO2 over time, and in the bottom strip you can see right after the arrow, right before the arrow, where the patient was stimulated, woke up, and began to exhale, and you can see the higher level of CO2. So in this patient, capnography detected that this patient was hyperventilating, and during stimulus and after stimulus, the patient began to breathe more regularly, exhaling a larger amount of CO2. So what are the respiratory depression criteria that we're looking at in a patient who develops respiratory compromise or airway obstruction when monitoring with capnography? One would be a change of respiratory rate. For example, breaths per minute less than 8 or even lower. Again, that may vary depending on the patient, so the low respiratory rate alarm may be something that's customized for that individual patient. We're looking for an end-tidal CO2 change of greater than 10 from baseline. That is up or down. We're not just looking for hypercarbia with end-tidal CO2, but we may look for a decrease in end-tidal CO2 as well, depending on the type of hyperventilation the patient's experiencing. We're going to look for an end-tidal CO2 value of greater than 50 millimeters of mercury, and we may look at, if the patient's on pulse oximetry, a pulse oximetry of less than 93% for 15 seconds or greater. The alarm limits should be customized to the individual patient for several reasons. One, because every patient is different. Two, because they are different, we can increase or decrease those alarms and change them, decreasing the amount of nuisance alarms that may cause alarm fatigue to the staff responding to them over time. And in that way, we customize to the patient and at the same time improve the ability of staff to respond to those alarms. For patients that develop respiratory depression, rescue interventions are aimed at improving airway and ventilation, calling help when necessary, and when necessary, drug rescue. Airway and ventilation interventions include being able to suction and provide basic airway maneuvers to reposition the patient's airway, and when necessary, insert a basic airway and assist with ventilations as needed. Calling a rapid response or medical emergency team in a timely fashion is important to bring additional resources to bear and prevent progression from a respiratory compromised situation into a full code situation. Drug rescue also should be used as needed based on the need of the patient, either naloxone or flumazenil rescue. This can be done either intranasal or IV depending on protocol and the patient need. So in closing, I think it's important that we really look again and consider what are the three parts that we look at in every patient: pre-existing conditions, clinical conditions, as well as treatment that put them at risk. Anticipating these risk factors are important because they can help us to decide who should be monitored with oxygenation and ventilation monitoring, customizing those parameters to the individual patient so that we detect those episodes that are important without creating alarm fatigue in the clinicians, preparing for unintended oversedation and rescue, reporting near misses and events. These are equally important to the actual events themselves as they help us to know who is at risk and also improve the system moving forward. And realizing that our choices have consequences in how we treat our patients, anticipating their needs, anticipating who is at risk, and using appropriate monitoring can prevent the untoward consequences in the future. In closing, I think it's important to realize that what we do for our patients and our care is both an art and a science. It requires mastery of assessment skills and the ability to understand both the benefits as well as the limitations of the technology we use in the treatment of our patients. And with that, I'd like to thank you for your time together today for this session.